So I welcome you all for this session on bone marrow transplantation. We will have four talks by some excellent speakers from Pakistan and from abroad, covering different aspects of allogeneic and autologous stem cell transplantation. We'll start off with a talk on acute graft versus host disease, preventive strategies and approach to steroid refractory and dependent cases by Dr. Mohammad Ayaz Mir. Dr. Ayaz is a clinical chief of bone marrow transplant unit at Shifa International Hospital. He is a diplomat American Board of Hematology and Internal Medicine, and he completed his fellowship from the Bone Marrow Transplant Center in Mayo Clinic, Minnesota. Over to you, Dr. Ayaz.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Ayaz Mir from Shifa Hospital, and I'm talking about acute GVHD preventing strategies and approach to steroid refractory and dependent cases. I have no conflicts of interest to declare, and I will discuss experimental use of drugs. So we all know how solid organ transplants are like. When you transplant a kidney or a liver in a patient, the graft does not fight back. It is at the mercy of the host because immunologically speaking, they are inert. In contrast to bone marrow or stem cell transplant, where your graft is a living immunological entity and will fight back and possibly kill the host if not controlled. So this is the journey our patients go through. They have to essentially convert from a host immune system to a graft immune system. And in the process, they meet the monster called chimera, where there's coexistence of two immune systems, and that is sort of the ripe period for graft versus host disease, at least the acute version. This is the classic mantra of transplant. You give an immune competent cells, and if these cells act against cancer cells, that's graft versus tumor effect. And if the same cells start acting against epithelial cells in skin, gut, and other tissues, that's graft versus host disease. So we discovered that T cells are the headquarters or the main character in this process, and there have been a myriad of efforts to inhibit T cells so that we can control this process. It's a very complicated cell, and there's multiple levels, multiple pathways that have to be inhibited. We learned this the hard way. The original efforts to inhibit T cells were through simple T cell depletion. And when we did that, the risk of relapse increased. This is from 1993. And we learned that T cells are the teeth of the graft. When you remove them, your graft versus host disease goes down, but the risk of relapse increases. Your graft is no good. Then we tried depleting T cells by more physiological means, such as with drugs like methotrexate and cyclosporin. And we discovered that T cell, the graft versus tumor effect and the graft versus host disease are essentially conjoined twins. There's no easy, simple, cheap technique to separate these two, and that is the holy grail of transplant. Not only that, when your patients get GVHD, actually their risk of relapse goes down. And that also tells us the value of dividing and separating T cells between good and bad. You cannot label them all bad and deplete them, or vice versa. Which brings us to Dr. Jekyll and Mr. Hyde, the good and bad self of the same person, where there's a transformation from good to bad, and we just need to figure out how to do that. There's 5 red flags of GVHD. There's 5 circumstances where you should be ready and anticipating GVHD. One is the degree of HLA mismatch. If you are doing an 8 out of 10 versus a 10 out of 10 transplant, expect more GVHD. Unrelated donors, which we don't do yet in Pakistan, but we have plenty of experience from abroad. They get severe GVHD, especially the acute. Female to male donor or preferred donor without any gender bias is always the young male. Females, especially multiparous females, have been exposed to different antigens and are high-risk donors for GVHD. Peripheral blood stem cell grafts are notorious for causing more GVHD. They have 10 times more T cells than your bone marrow. And conditioning regimen intensity, the more severe the injury to mucosa, more your chances of getting graft versus host disease. So different centers have tried different things. There's protocols for different transplants, mainly comprising of cyclosporin, methotrexate, mini-methotrexate, ATG, and other agents where we try to inhibit T cells. The timing of this acute graft versus host disease is critical. It happens after the patient engrafts usually. There's a hyperacute version of acute GVHD which can happen after first week, but it's very rare. Most of your GVHD will occur from third, fourth week onward, especially in the second month post-transplant. And that's how we divide it into acute and chronic GVHD. Roughly in first 100 days, it's labeled acute, and subsequently it's chronic, although there's overlap syndromes, and this is not a hard and fast division. Acute GVHD, there's no presentation on GVHD that'll be complete without ugly picture, so I'm adding my share. Acute GVHD is a Steven Johnson's-like disease with the burnt skin and rashes and angry-looking patient's skin composition. And chronic GVHD is more of a burned out scleroderma-like disease. How do we establish the diagnosis in 2021? Practically and realistically speaking, it still remains clinical. Your patient has rash, diarrhea, jaundice, you suspect acute GVHD. There's things that aid you like imaging, histopathology, and maybe blood tests someday. But right now, I think the bulk of diagnosis of acute GVHD remains clinical with maculopapular rash, gut findings, especially diarrhea and cholestatic hepatitis. These are the pictures you've all seen, and you've seen patients with them with palmar plantar erythema, rash, which is erythematous, angry looking, depending on the skin complexion, and can cover from a few percent to the whole body surface area. This is a CT scan of gut. You can see thickened ball loops with fluid in them, and that is by no means pathognomonic of GVHD. This is what you will see in a typical patient with GVHD, but that does not pin down your diagnosis. You can do an endoscopy and you can sometimes see pseudomembranes, erythema, ulcerations. Again, none of these is pathognomonic or diagnostic of GVHD. You can see this crypt apoptosis, which is a classic feature of GVHD. But in many centers, the pathologist may not be very experienced, especially if your volume is low, with picking up gut GVHD. And this, anyway, comes out a week after your patient has already started suffering. So the decision you have to make to start immunosuppression is clinical. People have tried hard to find out a troponin or a BNP sort of marker, a D dimer for GVHD, and they have turned to the molecules derived from epithelium, elafin, RAG3 alpha, cytokeratin 18, multiple studies of and cytokine combinations like IL-6, IL-12, and all this remains reference work as of yet. They are not widely available or applicable and have not been standardized for clinical use yet. So this is how we stage GVHD. Basically, more skin area you cover, more jaundice, more diarrhea, severe your GVHDs, and you can change it to grade 0, 1, 2, 3, or 4. And the reason we do that is there's a mortality curve. When you have grade 3, 4 GVHD, you're going to lose 80% of your patients. Steroid refractory disease is defined when 2 milligram per kilogram of steroid is given for a week or so, at least 5 days, and your patient is still not responding or getting worse. You know what you're dealing with. And there is a myriad, a bunch of second line molecules that people have tried, from ATG, brentuximab, pentostatin, stem cells, methotrexate, and all of these have a response rate mostly of 10 to 20% range. Patients are sick and nothing works. People have tried lithium. This is unpublished data from Fred Hutch, and they've shown mucosal growth with lithium and there is denudation, but there still remains experimental work. So here's our dilemma. You have Dr. Jekyll and Mr. Hyde, and what converts Dr. Jekyll to Mr. Hyde is this serum that Dr. Jekyll invented in his lab. He drinks that and he becomes his alter ego, the murderous, corrupt Mr. Hyde instead of the good self, Dr. Jekyll. And we need to find this serum. We need to find out what converts good T cells to bad T cells so we could control it and control GVHD. In a simplistic world, the B and T cells are simple cells, B cells the police, outside antigens, T cells the police, inside antigens that have already gotten into cells, like viruses. But in reality, there's a lot of crosstalk between the two. And we have tried inhibiting different components of B cells as well. For example, ibrutinib, we tried, and it does not work in acute GVHD. B cell is not a major player, at least in acute GVHD. It develops a role later in chronic GVHD, where rituximab works in some patients. Then we have tried antithymocyte globulin, which is derived from horses, pigs, and rabbits. You basically inject them with Jurkat, which is a cell line from a kid with TALL or other similar sources, and they develop an antibody, which is polyclonal. This is essentially an M&M. An ATG bag has antibodies to CD2, 3, 4, 5, 7, and multiple other antigens, and is not targeted at one particular thing. It is somewhat successful in preventing GVHD and sort of borderline in preventing acute GVHD, but it's not the magic bullet we're looking for. Calcineurin inhibitors change the face of solid organ transplants. They also have a major role in bone marrow or stem cell transplant, and we use them to cut the downstream T cell receptor signaling, which is calcium dependent, and that in turn inhibits the cascade of IL-2, IL-4, TNF alpha, interferon, and other bad players in the GVHD. But this is easier said than done. If you take IL-2, for example, everything in immunology is like a coin. It's the good and the bad in the same person. So you have IL-2, and if you see, IL-2 is responsible for the growth and proliferation of your effector or bad or alloreactive T cells. And if you inhibit it completely, you would think that everything will be fine. But actually, low levels of IL-2 are needed for Tregs to promote growth of good T cells. So you want to inhibit IL-2, but not too much. You have to find that sweet middle spot where you're promoting Tregs and inhibiting effector T cells. This is what happens when patients take too much calcineurin inhibitors. This is just one of the complications, hypertrophy of the jaw. So this was the ingenious approach by Lesnick and Fishes and colleagues at Johns Hopkins, where they studied mouse models and found out that if your T cells peak, the alloreactive T cells peak around day 3, 72 to 96 hours post allogenic stem cell or bone marrow transplant. And if at that time you introduce cyclophosphamide, which is a cheap T cell toxin, you can inhibit the bad T cells more than the good T cells. And this is the post-Cy protocol we use on day 3, 4 after haplo and now increasingly matched sibling non-myeloablative transplants. And that has shown to decrease GVHD significantly. Acute grade 2 to 4 GVHD went from 34 to 6%. But in the Lesnick and the Fisher's original BMT paper, the relapse rate was 52%. There's also increasing talk about gut microbiome. There's about a kilogram of bacteria that live in our bowel, and they were created for a purpose. They're doing something there. When we eliminate them with indiscriminate use of antibiotics, which is very common in our patients, such as with the beta-lactams, the incidence of GVHD goes up. So unnecessary use of broad-spectrum antibiotics should be avoided. This is also proven by the case series that people keep publishing about fecal microbiota transplantation, which results in improvement in some cases of refractory acute GVHD if done early enough. So remember, most of your patients with acute GVHD are going to die of immunosuppression, not of the disease, not of the GVHD. We get so scared, we immunosuppress them so much with multiple agents over a matter of days to weeks that from the mucosal injury, they develop sepsis and die. Other immune inhibitors people have tried are JAK2 inhibitors. The JAK-STAT pathway, if inhibited, will result in increased Tregs, the good T cells. These are REACH2 and then the REACH3 trials, which showed ruxolitinib, a JAK inhibitor, significantly improved response in acute GVHD, almost 60 versus 40%. And thrombocytopenia was the only major side effect. The chronic GVHD data from REACH3 is also available, which showed this agent is effective and is actually approved for GVHD. Other JAK inhibitors such as itacitinib are in trials and may provide more options in future. This is very interesting data. This is sitagliptin, a drug used in diabetes. which is a dipeptidyl peptidase 4 inhibitor, but it also inhibits CD26 and again, which is an a receptor on T cells. And when given in mega doses, about 12 times the dose you give to diabetic, 600 milligram, this was shown in a small study to bring down the incidence of grade 3, 4, 2 to 4 GVHD to 5%, and the non-relapse mortality was 0 at day 100. People have also thought about, because the reflexes when a patients develop GVHD or first run to drug is the steroid, and rightly so, they're cheap, they're universally available, we have a lot of experience with them. And people have tried to replace that reflex, the knee jerk, with other agents. So what if you give your patient sirolimus instead of steroids? And that was actually the BMTN Clinical Trials Network trial from 2015, which showed that yes, you can do that. You give people sirolimus instead of steroids 2 milligram per kilogram, and you'll have a similar response at day 28. Although this did not include patients, a lot of patients with the lower GI. Diarrhea is the killer mostly in acute GVHD. When people develop severe colonic disease, that's when the scary picture develops. You see a patient wasting before you, and that was not a large part of this trial. People have also tried alpha-1 antitrypsin for higher acute GVHD. Another BMT CTN trial from 2017 still going on. Then there's other techniques such as photopheresis, which works by dyes such as sorolin that you label T cells with, and it selectively removes your alloreactive T cells and leaves behind good T cells and sort of dampens the immune system by mechanisms, some of which are known, some of which are not. And it has data in acute GVHD. If started within first 10 days, about 60% patients could be salvaged. This is available in Pakistan. AFBMTC is offering it. But the problem is usually cost. The cost of one session is around 130,000 rupees, and you usually need multiple 8, 10, 12 sessions to see a response. So cost becomes prohibitive. People have tried combining approaches. What if we combine ATG with post-Cy? In this particular trial, the ATG was 5 milligram per kilogram and post-Cy was 50 milligram per kilogram. And they showed that they could dampen the response. The peak we see at 2 months, day 60, can be dampened with this approach, resulting in decreased incidence of GVHD. Well, post-Cy has its own problems. When you use post-Cy, cardiac toxicity increases, rate of infections increases, cardiac events increase. We're learning more about it as the use becomes more frequent. And hemorrhagic cystitis, the dreaded old complication, is of course there. We had a lot of hope in mesenchymal stem cells, which again are regulators that are supposed to raise the good T cells, the Dr. Jekylls, and decrease down Mr. Hyde. But the phase 3 trial did not show any magical effect. Some borderline data in high-risk patients, but in general, at this time, based on this publication in 2020, mesenchymal stem cells are not the hope, probably more hype. Which brings us back to this picture. What do we do? How do we find this serum? How do we separate the conjoined twins? How do we separate the good from the bad T cells? How do we find alloreactivity? And that's where the work is going on. People have tried inhibiting selective subsets of T cells, such as T cell alpha beta, along with CD19, instead of inhibiting everything, with reasonable results, but it's still a part that's cooking. And we'll see. There's a marker CD276, at least in mice, which identifies alloreactive T cells, and inhibiting this could result in inhibition of the bad T cells and leave good T cells behind, but it's still in the embryonal stage. One non-scientific, more social, realistic thing I should stress upon is that the patients should be counseled and consented carefully about graft versus host disease. And this should be a clear part of patient counseling when we're doing a stem cell transplant. So there's no surprise and shock reaction. It should be explained to them in simplistic terms, because it doubles the cost of transplant in most settings, especially in Pakistan, and it worsens the outcome significantly. There's a lot of things, natalizumab, the multiple sclerosis drug, nihilizumab, defibrotide is an anticoagulant, itacitinib, we talked about the JAK inhibitor, the HDAC inhibitors, bortezomib, the proteasome inhibitors, atorvastatin, Mehdi Hamdani had some work on this back in the day, and alpha-1 antitrypsin we talked about. But the ultimate goal remains to regulate T cells in a manner where they're still available for policing of the bad cells, the cancer cells, but leave our graft and host untouched and the cancer defeated. Thank you very much for your time.
Thank you, Dr. Ayaz, for a fascinating talk. We'll take questions right at the end. I think we'll move on to our next presentation. So that will be by Dr. Munira Musaji. She's a consultant hematologist and director of bone marrow transplant program at the Department of Oncology at Aga Khan University Hospital, Karachi. She's also a clinical associate professor and section head in medical oncology at Khan University. Dr. Musaji is going to talk about acute lymphoblastic leukemia and role of allogeneic stem cell transplantation in this particular disease. Over to you, Dr. Munira.
Good afternoon, Assalamu alaikum. My name is Munira Musaji. I am a hematologist oncologist working at the Aga Khan University Hospital in Karachi, Pakistan. And it is my pleasure to be here and to speak at the Shaukat Khanum meeting. And I want to thank the organizers for this invitation. So for the next about 25 minutes or so, I'm going to be delving into this daunting topic of the role of hematopoietic stem cell transplant in acute lymphoblastic leukemia. So we all do know that ALL cure rates decreases with age, and this is a very well-proven fact in children with who actually benefit from an almost 90% overall survival, with the overall survival decreasing significantly over the years. In patients which are less than 50 years, which are more than 50 years of age, have a survival of about 20 to 30%. Relapsed ALL does extremely poorly. This is data from the two large studies, UKLL2 and LALA94 study, looking at survival after first relapses. There was a significant number of patients in both of these groups. And what really proves the point is that when you're looking at a long-term outcome, the 5-year survival for this group of patients is less than 10%. So our best shot for cure is to treat them with the best possible treatments upfront and to give them the best benefit. Knowing the risk factors for adult ALL are extremely important. That is how you risk stratify your patients when they come into clinic. The age-old ones which have been there is an age as a cutoff and a WBC count. These two risk factors now are less increasingly important in the era of molecular profiling and MRD assessment. Looking at the molecular signatures, patients who are Philadelphia positive, patients who have a Philadelphia-like ALL, and I'm going to talk about this later in my talk. Patients with other chromosomal aberrations, the T411, 11q23, hypoploidy, they all do poorly and they need to be dealt with separately. Patients who have CNS involvement is a particularly high-risk group. And one of the most important risk factors to emerge over the last couple of decades is MRD, or measurable residual disease. And if a patient is MRD positive after induction, they have been shown to have a very poor outcome, and I'm going to talk about that a little later as well. So when I do see a patient in clinic with ALL and they are coming to me for a transplant evaluation, there are certain things that really go into my mind, and I'm going to divide my talk into three important aspects. One is, what are the indications for the transplant for this patient? The second will be related to the nitty-gritties of the transplant procedure itself, and then what do we do with the patient at the end of the transplant. So when you're looking at the indications for the transplant, I will discuss about indications of allo transplant in both Philadelphia negative and Philadelphia positive disease. Should the patients who are adolescents and young adults be treated differently? What is the role for MRD assessment and why is that important? And should the abnormal cytogenetic, molecular, phenotypic risk really be considered when you're making a transplant recommendation? So This large review was published by the Cochrane Review authors in 2011. So this is an older study. They looked at a group of 3,000 patients spanning about 14 trials, spanning over a decade or so. And they looked at all patients who underwent an allogeneic stem cell transplant in ALL. Looking at that patient, the trials that were selected, all of them were sibling donors, all of them were older patients than 15. So this doesn't really apply to the pediatric group or in patients who were treated with a pediatric inspired regimen. They all received a myeloablative conditioning with TBI, and they had, what was noted was an increase in non-relapse mortality. Looking at the data regarding allo stem cell transplant, across all of these trials, there appears to be a significant hazard ratio of 0.86, benefiting the donor group. This was also solidified or observed in the standard versus high risk group of patients. And in the same group, patients having a donor tended to do better than patients who did not have a donor. Taking this a little step further, now looking specifically into the Philadelphia negative ALL, this paper published in Blood in 2015 looked at the high risk group of patients from the two GRAL study, 2003 and 2005. They were able to select out about 522 patients, out of which 282 underwent a transplant, 240 remained on chemotherapy. And it really appeared that patients who were high risk and who underwent a transplant, they tended to do better than patients who did not undergo a transplant. Now, when you're looking at what is the regimen to use for patients with ALL and how does that really affect the outcome, with the advent of the use of the pediatric inspired regimens for patients with for adult patients with ALL, we have consistently seen over the years marked improvement in overall survival in patients who will use the pediatric inspired regimens. Just to refresh the memory for the participants, pediatric inspired regimens tend to have more vincristine, tend to have more asparginase and corticosteroids, therefore the toxicity is slightly higher and then needs to be looked at. They emphasize very greatly on the timely administration of therapy, and a very stringent MRD assessment is done so as to select out those patients who are going to do well in the long run. The intergroup CLGB have also looked at a pediatric-like regimen in patients with adolescents and young adults. These were all patients who are between the ages of 15 to 40 years. So it spanned about quite a large age group. The protocol is given right here. This was a prospective study. And what really points out is that patients who were treated in a very intense regimen had a markedly improved event-free survival of close to 78 months. Overall survival was not reached. When you compare it to the historical control of the CLGB study, it was about 30 months. So, this is almost tripling of the survival. How does when you're treating somebody with a pediatric inspired therapy, what is the role of allografting in patients with ALL? So this is a CIBMTR analysis, which pretty much answered this question. And they looked at the cohort of 422 patients who underwent a stem cell transplant, and those who were treated with a pediatric protocol such as the BFM. And what is really striking is that whether it is overall survival or disease-free survival, patients who were treated on chemotherapy alone did far better than patients who had hematopoietic stem cell transplant, owing to the fact of a higher transplant-related mortality and non-relapse mortality in transplant. Looking at the subgroups of patients, chemotherapy still trumped all different subgroups with respects to patients who achieved a CR early, or whether they received a MUD or SIP transplant. The bottom line is the patients who are going to be candidates for a pediatric inspired regimen should be treated as such, and those patients who are probably standard risk will probably benefit from chemotherapy alone. What is the outcome of patients of Philadelphia positive ALL? This was looked at in a prospective LALA 94 study, which is an older trial published in 2002. looked at about 154 patients with a median follow-up of 4.5 years, and in which about 103 patients underwent a transplant. So patients who underwent a transplant had an improved outcome compared with patients who did not undergo a stem cell transplant for Philadelphia positive ALL. Moving on, they also looked at how did transplant compare with chemotherapy in another large UK study, which is a UKLL12 study. Whether you underwent a sibling or a MUD, you did better than compared to chemotherapy alone for Philadelphia positive ALL, and SIB allo transplant did better than unrelated donor. The US intergroup looked also in an adult population with Philadelphia positive ALL, and in this they looked at the addition of dasatinib, which is a tyrosine kinase inhibitor against BCR-ABL, along with chemotherapy, which was hyper-CVAD for this protocol, and they prospectively looked at the Philadelphia positive population. Two things really points out by the study. One is that with the advent of dasatinib, you have an improvement in the survival, which is seen by improved overall survival in the relapse-free and the overall survival close to about 80%. In the landmark analysis of transplant versus no transplant, even with the use of TKIs, patients did better when they did receive a transplant. Transplant really did improve outcomes for patients with Philadelphia positive ALL, and even when they were given before transplant, as was the case with the previous trial, or they were given post-transplant as prophylaxis, as demonstrated by this EBMT analysis of TKIs in patients with Philadelphia positive ALL, both pre and post-transplant, documenting an improvement in leukemia-free and overall survival for both of these groups of patients. Now the paradigm for management of Philadelphia positive ALL is changing slightly with the advent of the new BiTE inhibitors, which are really changing how we really treat ALL. So this was a landmark study which was published in NEJM last year, and I wanted to talk about this because this is going to be the future of how we're going to really manage patients with adult patients with ALL. So I'm sure all of you are aware of this study in which dasatinib and blinatumomab were used for Philadelphia positive ALL. This was a small study, 63 patients, in which they received a combination of dasatinib and blina. What is really important to note is that about half of these patients went into a complete molecular response by using just a non-chemotherapy based combination. The overall survival for this group was almost 98%. 24 patients underwent allo transplant, and 74% of these 24 patients were those that had an MRD positive after induction. And the last kicker of this entire study was a very low transplant-related mortality, which is intuitive because these patients really did not receive a chemotherapy prior to their transplant, so they're in a relatively well-preserved state. So this is a direction to watch out for, and I'm sure as more and more studies comes in, how we place these drugs in the treatment of ALL and where does transplant fit in is going to be really the next question. MRD is a very important prognostic factor on survival for ALL. MRD, which is now known as measurable residual disease, is really detected by sensitive methods with either flow cytometry that we use very frequently, or if you have a genetic aberration, then you can either use FISH or PCR. And it has been demonstrated repeatedly in many trials. It results in patients who are MRD positive will do very poorly compared to patients that are MRD negative. This was again demonstrated by the CIBMTR analysis of 806 patients. Patients with a negative MRD have an overall survival at 5 at about going out to 10 years at about over 50 to 60% versus about 10% which are MRD negative. And this is irrespective of any of the other high risk features. MRD monitoring, both pre and post-transplant is important. Post-transplant, it gives you an idea of who's going to do poorly. Patients who are MRD positive post-transplant will relapse and have a very poor and have a very poor survival. Other cytogenetic risk factors are again important to consider, and this is to keep in mind of everybody that 411 translocation, hypodiploid karyotype, Philadelphia positive, and other cytogenetic abnormalities, and Philadelphia-like do much worse compared to the others. So that really needs to be taken into account when you're seeing the patient. Shifting gears a little bit, and I'm going to talk about the transplantation-related factors. So we're going to talk about what conditioning and intensity to pick, whether reduce or MAC conditioning, to use TBI or not to use TBI, and should we consider any alternative donors when we are really talking about transplantation. So quickly delving into the question of RIC versus MAC, this has been tested in multiple studies, and I'm going to talk about one or two of them. First patient cohort of Philadelphia negative ALL, there was no difference on MAC versus RIC, either with regards to transplant-related mortality or leukemia-free survival, but there did appear to be an increased risk of relapse in the patients who received reduced intensity conditioning. However, in this study, this was not statistically significant. Looking at Philadelphia positive ALL, similar data with no difference in disease-free survival and overall survival with a non-significant p-value, slightly higher treatment-related mortality with MAC as to be expected. But what's really important is that whether the patient's MRD positive or negative really factors into your decision making, or whether to do a myeloablative conditioning or to do a reduced intensity conditioning. The patients who were MRD positive and who received a RIC conditioning tended to have a much higher probability of relapse versus those who received a MAC conditioning. So that is a very important point to note. TBI or no TBI, pick your poison. If in this study reported in 2018, patients who underwent a TBI-based regimen tended to have a much lower risk of relapse compared to those that received a busulfan regimen. So probably if you're going to do MAC conditioning, TBI would be the way to go. Now in a group of patients who do not have a matched sibling donor, can we use an alternative donor? And I'm going to limit my talk to haploidentical transplants because we really don't have a bone marrow registry here in Pakistan, so we don't have that experience with matched unrelated donor. So looking at haploidentical transplant with post-transplant cyclophosphamide, this is a report for the EBMT working leukemia group, and what this study really clearly stated that patients who undergo a haploidentical stem cell transplant in CR1, they do very well with a survival of almost at about 2 years, about 50 to 60%, which is comparable to your matched sibling donor if you look at the historical controls. Patients who have advanced disease, they're going to do poorly regardless of what you do. So haploidentical transplant is a likely viable option. I'm going to skip this slide, which pretty much says the same thing, that patients who have bad disease are going to do poorly. And I'm going to delve right into a much larger cohort study where the CBMTR and EBMT joined hands to collect patients of almost 15,000 patients divided those who received a haploidentical transplant versus a matched unrelated donor. And looking at 3 endpoints, 3-year overall survival and graft versus host disease, there was no difference in 3-year overall survival. There was no difference in acute or chronic graft versus host disease in this group. So haploidentical transplants is really something that could be and should be considered in high-risk patients. What to do post-transplant? This is especially important in patients who are Philadelphia positive. The question would be to give imatinib or not to give imatinib or other TKIs. As we discussed earlier, that patients who receive tyrosine kinase inhibitors, both pre and post transplant have an improved survival. The question really is, should this be used prophylactically, or could this be MRD triggered? I was able to find a small study of almost 26 patients in both arms. This was a prospective study in which patients were divided into two cohorts. One cohort was whether they received MRD, whether they received imatinib when they were MRD positive, and the other cohort was when they were given imatinib prophylactically. There was no difference in survival between both of these cohorts, so both can be a viable option. This is the same data for the same cohort looking at relapses, and there was no difference in relapses between these two cohorts as well. So both options are viable. I think my preference and a lot of transplant physicians' preferences would be to do imatinib prophylactically. Patients tend to tolerate it well, and it really negates the need for very rigorous MRD screening. Just the last few slides have wanted to touch upon Philadelphia-like ALL, because this is an entity which is of extreme significance. So about 33% of all ALLs will be Philadelphia-like as determined by a gene signature. And in the Philadelphia-like, you will have a group which is going to be a high-risk group, such as those which is CRLF2 positive or Icaros positive or JAK2. And there'll be about 30 to 40% which are going to be non-CRF4. Why this is important to note? Because patients who are CRLF2 positive, they tend to have a marked decreased overall survival, and they actually tend to do worse compared to all of these other groups. So a quick algorithm on how to manage patients with Philadelphia-like, which is, it really follows the same ethos as we do with the rest of ALL. Patients who are in CR1 and who have no high risk features, you can continue them on protocol, but you have a young patient and a very good donor, then you might want to consider transplant. However, if you have any of the high risk features, such as your MRD positive or presence of these high risk mutations, using one of the newer targeted therapies and an allogeneic stem cell transplant would probably be the way to go. So the take home points, I'm going to try and answer some of the questions that I raised earlier in my talk. And these are just my analysis and my interpretation, and we're happy to discuss it in the question and answer session. With regards to the indications for the allo stem cell transplant in chromosome negative and positive disease, what is very clear in my mind that patients who are Philadelphia negative and who are MRD negative, and you treat them on a pediatric inspired protocol, these are the patients who will benefit from chemotherapy alone. And allogeneic stem cell transplant is left for a later date if needed. For Philadelphia positive, still probably recommend transplant in CR1. Obviously with the ongoing debate is, how do you incorporate these novel antibodies and the new third generation TKIs such as ponatinib? Would you still need transplant if somebody is MRD negative when you're using the newer drugs? That is something that we can debate on further. What is the role of MRD assessment? Cannot be stressed enough. It is absolutely essential. It is the most important prognostic factor for outcome, whether your patient's going to do well or is going to do poorly. Should we be looking at cytogenetics and molecular and phenotypic risk? The answer is yes. It allows us for better characterization of the disease and allows us to really follow up the patient well, and if there's a genetic marker, follow that marker. Regarding the conditioning intensity, MAC versus RIC, there appears to be no difference in survival. However, decreased relapses with MAC. And it is really the disease and the transplant-related factors and MRD which will influence our choice. To TBI, to not to TBI, as I said before, if you're using MAC, conditioning, TBI is likely going to still be preferred. Alternative donors, very viable option. If you don't have a matched sibling donor, a high-risk patient, please consider for haploidentical. The more experience that we have with this, the better we are going to do in the long run. And the indications for post-transplant maintenance therapy for ALL, definitely TKI as either maintenance therapy, whether you do it prophylaxis or preemptive, that's your call. However, I think prophylaxis will be preferred by almost all physicians. How long to continue, which TKI is preferred is something that we can always debate upon. And I'm going to end right there, and thank you so much for your attention and looking forward to your questions.
Thank you, Dr. Munira, for a very comprehensive talk on ALL and allogeneic stem cell transplantation. We'll move on to our next speaker. I'm pleased to welcome Major General Dr. Kamran Chaudhary. She is a consultant hematologist and the director of Armed Forces Bone Marrow Transplant Center. She's one of the pioneers of bone marrow transplantation in the country and established the Haploidentical transplant program at her center. She has a special interest in bone marrow transplantation in aplastic anemia. Her talk is going to be on haploidentical transplantation overview and its outcomes. Over to you, Dr. Kamran.
Assalamu alaikum and good afternoon. First of all, my gratitude to the organizers for arranging this wonderful event and for inviting me to participate. My name is Kamran Chaudhary. I'm a professor of hematology and a bone marrow transplant physician at the Armed Forces Bone Marrow Transplant Center in Rawalpindi. I'll be talking about haploidentical hematopoietic stem cell transplant, and I'll be focusing a bit on our local experience here. So I have no disclosures or conflicts of interest. Let me start by introducing you to this 5-year-old girl who presented to us in October 2014 with very severe aplastic anemia. HLA typing of their family did not reveal an HLA match. In the meantime, she continued to have episodes of neutropenic sepsis because of the very low neutrophil count. She was offered a haploidentical transplant, which she underwent on 28 August 2015, and the donor was her 7-year-old elder sister. This was our very first haploidentical transplant at this center. Today, she's 6 years post-transplant. She's a student of class 5, and you can see her here with me and other patients in this photo that was taken a couple of years ago. So haploidentical transplant is an option for patients who do not have an HLA matched donor, and it's being used increasingly both in Europe and the Western world as well as in China, where nearly 60% of transplants are haploidentical. Coming to the genetics of HLA matching in haploidentical transplant, HLA alleles, both class 1 and class 2, are inherited as haplotypes from the parents in a Mendelian fashion. So there are 4 haplotypes, 2 from the mother and 2 from the father, and there are 4 possible combinations. So each sibling has a 1 in 4 or 25% chance of being fully matched with another sibling. But if you need only half matching, then the chances are double. So there's a 50% chance of being haplomatched with another sibling. So we have 2 haplomatched siblings in this family, for instance. So the major advantage of haploidentical transplantation is that a donor can be found for almost every patient, nearly 95% of patients, in fact, who need a transplant. And usually there are more than 2 donors in the family. So the parents, the siblings, the children, nephews and nieces, and even grandchildren. It does not require a donor registry or a cord blood bank, and that is a major plus for under-resourced countries like us. The donor is highly motivated, being a family member, and is available for post-transplant cellular therapies such as a boost, a DLI, or even a second graft. In the Western world, the immediate availability of the donor is a major plus if an urgent transplant is required, for instance, in high-risk acute leukemia, or for patients from smaller ethnic groups who are underrepresented in donor registries. So if there are more than one donor in a family, which is the best donor for the patient? The EBMT has set forth its consensus recommendations for donor selection. These were published by Churia and colleagues last year. And these are our criteria, quite close to the Johns Hopkins criteria. Whichever criteria you use, the single most important factor is that there should be no donor-specific anti-HLA antibodies at the level of a cytotoxic cross-match. Because if there are anti-HLA antibodies in the recipient, they're going to lead to graft rejection, to poor graft function, delays in engraftment, and reduce overall survival. So this is the single most important factor. Other factors are relative, so that you need a younger donor is going to be better over an older donor, male donors for male patients rather than a female donor. And there are other relative factors, but there is no prioritization for the degree of HLA mismatch. And this is important, and it's quite different from what happens in matched unrelated donor transplants or in cord bloods. So what really dictates the outcome of a haploidentical transplant is the fine balance between the lymphocytes of the donor and the recipient. On the right side panel here, you can see that the donor lymphocytes are going to allow rapid engraftment, fast immune reconstitution, and have a graft versus leukemia effect, which is useful in controlling the malignancy. On the other hand, because of this big mismatch in the HLA, there is this inevitable risk of graft versus host disease. And for a successful haploidentical transplant, you need to have some kind of deep cell depletion strategy. So you can do this ex vivo, or you can do it in vivo by using antibodies like ATG and Campeth, ATG or Campeth. The other side is that if extensive T cell depletion is done, then this can lead to increased graft rejection, slower immune reconstitution and consequent infections, and a less strong graft versus leukemia effect and disease relapse. So a very fine balance required there for a successful outcome. So several transplantation platforms have been developed for successful haploidentical transplant, and these are the three main approaches. We're going to look at them one by one. The first is the T-cell depletion platform, and this was pioneered by the group at the University of Perugia in Italy, and we saw these studies coming out in the mid-90s. So a mega dose of stem cells to overcome the risk of graft rejection is given, and T cells are depleted can be depleted using several strategies. So one is to positively select the stem cells, CD34 selection, or deplete all of the T cells or different populations of T cells. Now, the major advantage of this approach is the very low risk of graft versus host disease. So most recipients would not require post-transplant immunosuppression, and this can be a particular advantage in certain patient populations. On the other hand, there is, of course, the risk of graft rejection and of infections. So when we see these studies looking at T-cell depletion platform, we see that there is very little graft versus host disease except in the earlier studies, but non-relapse mortality is quite significant, as is relapse. Also, this particular platform tends to be expensive because you need to have specialized dedicated laboratories. And if a post-transplant adoptive T-cell transfer is required for immune reconstitution, then this can be quite expensive. So coming to the second platform, this is popularly known as the Beijing Protocol. Or the JIAC Protocol, and this was pioneered at the Peking University. And what this involves is giving GCSF to the donor this GCSF would mobilize stem cells and prime the bone marrow to increase the stem cells. It would also cause immune modulation of the donor lymphocytes. This large T cell replete, these are the T cells. Graft is given to the recipient after conditioning, and ATG is included in the protocol. Now, ATG is going to target both the donor lymphocytes in the graft as well as the recipient lymphocytes. And post-transplant immunosuppression is again intensive with the calcineurin inhibitor, short methotrexate, and MMF. Now, the advantage of this particular protocol is that it leads to almost universal engraftment in most studies. And the downside is graft versus host disease, both acute and chronic. Non-relapse mortality is quite acceptable, as is the low relapse risk. This protocol is being used not only in China, but elsewhere, but primarily in China. So the major breakthrough in haploidentical transplant came with the discovery of post-transplant cyclophosphamide. This was pioneered by the Baltimore group at Johns Hopkins in the year 2001. And what this particular platform involves is the use of cyclophosphamide, which is given after the infusion of stem cells. So here we can see it in more details. Bone marrow or bone marrow plus PBSC or PBSC alone can be used as a graft source. The T cell replete graft is infused into the recipient after conditioning, and this is followed by post-transplant cyclophosphamide, which is given on day +3 and +4. So how this works to prevent graft versus host disease is not entirely understood. Previously, it was thought that PTCy eliminates alloreactive T cells both in the graft and in the recipient. More recent work has shown that it does not actually eliminate them, but it causes immune modulation and immunosuppression. So these cells become functionally impaired. The second major aspect of PTCy's effect on GVHD is because it allows a preferential proliferation of Tregs, and you can see this here. And this is a very integral component and very important to prevention of graft versus host disease. In addition to PTCy, tacrolimus and MMF are part of the post-transplant immunosuppression in this particular platform. So this has become increasingly popular because of its safety, the low cost, and here you can see that more recently, 90% of haploidentical transplants in the US are by PTCy in preference to other post-transplant immunosuppressions. So we will be looking at a few studies for haploidentical transplant. And I just want us to go through the comparisons with other donor sources. The major indication for haploidentical transplant in this CIBMTR data slide, as you can see, is acute myeloid leukemia, followed by ALL and MDS and myeloproliferative neoplasms. So malignancies mainly. And this paper, based on the CIBMTR database, compares the outcomes of haploidentical versus matched sibling donor transplantation for acute myeloid leukemia in first complete remission. So this is a large study. They looked at 1,205 adult patients. 336 patients underwent a haploidentical transplant, 869 a matched sibling transplant. And when we look at the results in terms of the overall survival, the leukemia-free survival, relapse risk, non-relapse mortality, and acute graft versus host disease, we see that the curves overlap very closely for both haploidentical and matched sibling donor transplants. And the surprise is here in the curves for chronic graft versus host disease, where you see that there is a significant difference between the low risk of graft versus host disease, chronic graft versus host disease for haplotransplants versus matched sibling donor transplants. So the second major study is again a registry study done by the Acute Leukemia Working Party of the EBMT, and they looked at 1,234 adult patients with ALL. And this is an important study because historically the results of T-cell depleted haplo transplants with CD34 cell megadose, the first approach, gave very poor results for acute lymphoblastic leukemias compared to AML. So here they've again compared haploidentical donors with, this time with matched unrelated donors, 10 by 10 matched, who were 809 in number, 136 haploidentical, and 289 mismatched, 9 by 10 matched unrelated donors. Half the patients, nearly half of the patients had Philadelphia positive ALL, and about a quarter Philadelphia negative B-ALL, and 29% patients had T-ALL. And again, when we look at the results in terms of relapse, non-relapse, mortality, acute graft versus host disease, and chronic graft versus host disease, we see that there is no significant difference whatsoever. So based on these and other studies, we see that the results between a haploidentical donor are comparable with those of matched sibling donor and matched unrelated or one antigen mismatched unrelated donor. This relapse risk is not low actually in comparison to transplants from HLA compatible donors. And this is of course a bit surprising because one would expect that there being a major mismatch between the HLA, the GVL effect would be stronger in a haploidentical donor, but that's not the case. Disease status at transplantation is a major factor impacting the outcome, and this is like any other allogeneic transplant. And conditioning intensity impacts relapse in younger patient. Again, this is like matched sibling or matched unrelated donor transplants. So coming to aplastic anemia, this is an area of interest for us. And I'm going to be sharing this study that has come out of Johns Hopkins. They looked at 37 patients, some of whom had previously been treated with immunosuppressive therapy and had either relapsed or had refractory severe aplastic anemia. And some of the patients in this study were treatment naive. All underwent a haploidentical transplant with this conditioning regimen based on ATG, fludarabine, cyclophosphamide, and TBI. The first few patients were treated with 200 centigrade of TBI, but this led to a high rate of graft rejection, and this was increased in the later patients to 400 centigrade. GVHD prophylaxis was with PT-Cy plus MMF days 5 through 35 and tacrolimus days 5 through 365. And this is the overall survival, and overall survival of 94% in all patients, 100% in relapsed refractory patients, and 86% in treatment naive patients. And this is probably explained by the fact that treatment naive patients had never received any kind of immunosuppression before. The GVHD free survival was quite good. GVHD, the incidence of GVHD was 11% for acute graft versus host disease and 8% for chronic graft versus host disease. So quite good results, but a very small group of patients. This is a systematic review and meta-analysis of clinical outcomes, and this has been done on behalf of the Severe Aplastic Anemia Working Party. Again, a registry study from the EBMT published last year in bone marrow transplantation, and they looked at a total of 15 studies with 577 patients with a variety of conditioning regimens. GVHD prophylaxis was PT-Cy in 3 studies only, but the results are quite good here, successful engraftment in 97% of patients, and Allo TRM. Graft versus host disease, acute grades 2 to 4 was seen in a quarter of the patients, and chronic graft versus host disease again in a quarter of patients. So would we want to choose upfront haploidentical transplantation in patients who do not have an HLA MASH donor and have severe or very severe aplastic anemia? Well, that's a difficult question. The results of immunosuppressive treatment have been suboptimal overall, and this is according to NIH data and our own experience. The results of addition of EPAC, which has improved overall survivals to 97%, nonetheless, there is the complete remission, complete response rate is between 26 to 58%, and there's a significant risk of relapse. Also, chronality is not eliminated, and patients can develop MDS, PNH, acute myeloid leukemia, and an abnormal karyotype. And this can start as early as 6 months of EPAC initiation. Also, neutrophil recovery takes about 3 to 6 months, and particularly in very severe aplastic anemia. And in the meantime, these patients can succumb to severe infections. Equine ATG is not available for a lot of the time. Its availability is precarious, and it costs twice as much as rapid ATG, at least in Pakistan. And although it is more effective, and also addition of EPAC to immunosuppressive treatment in younger patients has not been seen to improve response rates. And this is particularly important because we see a lot of younger patients, and that is in fact the main patient population, pediatrics and young adults. So one could consider, given in the light of the studies that we've just seen, upfront haploidentical transplant in younger patients with severe and especially very severe aplastic anemia. So coming to our own data, we have done 37 haploidentical transplants so far, so it's a rather small number. 63% of the patients were male, 37 female. The age range is from 1 year to 39 years. 21 patients had aplastic anemia, 9 acute leukemia, AML, ALL plus 1 high-risk MDS, and 7 patients had a variety of immunodeficiencies. These are pediatric patients. These are the conditioning regimens. We do not have access to TBI, so busulfan in all of the regimens, as well as ATG for GVHD prophylaxis. And we have used post-transplant cyclophosphamide plus cyclosporin. We do not, as a matter of routine, use tacrolimus plus MMF. So the median stem cell TNC dose that we've used is quite high, 8.7. The lowest is 3.3. Median CD34 cell dose has been quite good as well, 6.7. The lowest, 3.2. We've seen neutrophil engraftment in our patients at a median of 15.6 days. Primary and secondary graft failure have been major problems, particularly in aplastic anemia patients. We were able to rescue only 1 patient with a boost. The remainder of patients died. Acute graft versus host disease was seen mostly grade 2, but we have lost 1 patient due to extensive graft versus host disease post-boost. Chronic graft versus host disease in only 2 patients. So the stem cell source that we've used, 55% bone marrow, in about 1/3 of patients, bone marrow plus PBSC, and in a very small fraction, PBSC alone. That's not the preferred stem cell source for us. Patients who received more than a TNC of more than 5 had a high risk of GVHD. Very few patients received a TNC less than 5, but we did not see any GVHD in any of them. Patients who received a graft from their parents had a risk of graft versus host disease of 40%, double that when there is to those patients who received a graft from a sibling donor. So we have a very high CMV positivity rate, nearly 90% and 92% here at the outset, and post-transplant CMV reactivation was seen in nearly 80% of patients, but we did not have any CMV disease. So these are the causes of death. We lost 17 patients. So graft failure is a major part of this, but we lost 2 patients to ongoing sepsis. So these were patients with severe combined immunodeficiency who were taken to transplant with an ongoing infection. 2 patients died with coronavirus, unfortunately, and we lost 1 patient to an accidental death after successful transplant. So this graph shows the overall survival of our patients. Acute leukemia, 77.8%. 2 patients died, 1 MDS due to TRM 14 days post-transplant before engraftment, and 1 patient of acute leukemia who had successfully engrafted but died because of COVID. So, for immunodeficiencies, the results are not so good as for aplastic anemia. So overall survival of 52 and 52.6%. Graft rejection was a major problem in both these groups. So the question is, why poor haploidentical transplant outcomes in our patients as compared to the Western data that we've seen earlier? So the first, of course, is that we do have a lack of experience. Transplant and haploidentical transplant in particular is a steep learning curve. With more experience, we may have better results. This is in addition to the lack of advanced lab facilities which are lacking, like high resolution HLA typing or genetic testing for inherited bone marrow failure syndromes. Transfusion services in Pakistan, unfortunately, are atrociously, poor. There is a very high risk of alloimmunization, and in fact, a lot of our patients of aplastic anemia have received a large number of transfusions before they land with us for transplant. There's also the heavy burden of infectious diseases, tuberculosis. You saw the CMV positivity in our patients, and then there are fungal infections, hepatitis and multi-resistant bacteria, and then there's the endemic poverty plus malnutrition and other factors. So to conclude, haploidentical hematopoietic stem cell transplantation is an effective treatment option for most clinical indications for patients lacking a matched-related donor. It's a viable option for resource-constrained countries like us, and that makes it very important for us. And of course, further experience and refinement in protocols is likely to improve outcomes. This is our team at the FBMTC. I'm extremely grateful to them for the patient care that they've provided, and of course, for contributing to the data that are presented today. Thank you so very much for your attention. I'll be very happy to answer any questions you may have during the panel discussion.
Thank you, Dr. Kamran, for such a fantastic talk on haploidentical transplantation and also an overview of the results in your center. We will move on to our next talk. So I'm glad to invite Dr. Kamran Curley to present the next talk. Dr. Curley is a clinical hematologist and the acting director of the Department of Hematology and Bone Marrow Transplantation at the Royal Brisbane and Women's Hospital in Brisbane, Australia. He's also a senior lecturer at the University of Queensland. His areas of special interest include the management of acute leukemias and, of course, allogeneic hematopoietic stem cell transplantation. He has a large number of publications in a number of peer-reviewed journals. Dr. Curley is going to be talking about a difficult topic, management of post-transplant relapse. Over to you, Dr. Curley.
Welcome. I'm Dr. Kamran Curley. I'm the director of the Department of Haematology and Bone Marrow Transplant at the Royal Brisbane and Women's Hospital in Australia. And I want to thank the organising committee for the invitation to speak today. Today, my topic will be relapse post-allogeneic stem cell transplant. Now, this perspective of the speaker is particularly relevant, and my perspective comes from that of being a transplanter in the state of Queensland in Australia. And many of you probably know that Australia is large, but not as dense as many other populations. So the size of Queensland might be twice that of Pakistan, but the population is not even half that of the city of Lahore, at a population of 5 million. But we do provide transplants for the whole of the state. And so as a result, we are one of the largest allograft units in Australia. We do about 160 transplants a year, and we do a number of unrelated donor collections. What do we treat? We treat mainly acute myeloid leukemia. And so the focus of today's talk will be primarily talking about relapse in this condition, which is one of the ongoing areas of unmet need. We also do transplants for non-Hodgkin lymphoma, myelodysplasia, and ALL. So the perspective is also one of a T replete centre. So T-cell depletion is not part of our standard of care for primary transplant of malignant disorders. And this has some impacts on outcomes post-relapse. And we also use peripheral blood stem cells, as you can see from this bottom graph, as our primary sources of cells, again associated with higher rates of GVHD. And so the relapses we encounter can be particularly challenging. So why is relapse important? Well, there's been a lot of advances in the outcomes of patients receiving allogeneic transplant for all indications, including AML. And the significant gains have been made in reducing the non-relapse mortality. And you can see here in the graph on the left-hand side that non-relapse mortalities in our institution have continued to reduce and are now down to levels as low as 3 to 14%, depending on the conditioning regimen used. So this is a series of 116 adults transplanted over 4 years with about a 2-year median follow-up. But as you can see in the right-hand curves, we still have significant problems with relapse. And even in our myeloablative conditioning regimen, we see about a 36% relapse incidence. So relapse is our commonest reason of treatment failure from this treatment. And as many will know, the survival post-relapse universally is poor. So this is curves and data from one of the largest series published looking at relapse post-allograft, an EBMT series, now a bit dated from about a decade ago, which shows that overall survival is well under 20% for all those who relapse post-transplant, getting down to levels of less than 10% with more prolonged follow-up of 5 years. So what are the prognostic factors post-relapse that impact outcome and survival? Well, there are a number of established prognostic factors that really come across in all published series, and they really relate to age, as is often a prognostic factor in hematological malignancy. It's clearly borne out in post-relapse situation for AML post-allograft, with those less than 20 having a better survival than those over the age of 20. Time to relapse is universally an adverse prognostic factor. So the time period really in most series comes out at about 6 months. So those relapsing quickly post-transplant tend to have a far worse outcome with all subsequent therapies thereafter. Some series have shown out to 12 months, maybe considered anything the first 12 months an early relapse, but really most of the data sits with 6 months. Chemosensitivity, so those patients that have a relapse, particularly of AML, that can attain a second remission, clearly have a significantly better outcome, not as everyone would expect. So what other prognostic factors are there? Well, performance status is important, as one may imagine. GVHD prior to relapse is important. So some publications have really linked to acute GVHD prior to relapse being important. while others have looked at more chronic graft versus host disease. But they certainly have not been borne out in all publications. Bone marrow blasts can be important. So certainly several series have shown that bone marrow blasts less than 25% may be a more favourable mechanism of relapse. And prior T-cell depletion prior to the relapse is clearly an important factor, with some of the best outcomes being published for relapsed leukemia post-transplant occurring in those T-cell depleted populations where a strong graft versus malignancy effect may not have been enacted prior to relapse. So what's been the local Australian experience, on prognostic factors post-relapse? Well, we're able to look at a series of 386 patients who had relapsed post-allogeneic transplant with AML from 9 centres across Australia over a decade period. So quite mature, prolonged follow-up on these patients. And we found very similar results here, with survival being very poor for a vast majority of patients. Prognostic factors, however, that we could tease out were similar. We found time to relapse less than 6 months as an important determinant of an adverse outcome, but also prior severe acute graft versus host disease in our series was the other major determinant that came out in multivariate analysis. So the blue curve shows the survival of patients relapsing whom relapsed after 6 months post-transplant and had not experienced acute GVHD of any great severity. So I guess these results did show us that there is a proportion of patients who potentially can have a reasonable long-term outcome with very mature follow-up there with some forms of therapy after relapse post-transplant. So how do we treat relapse post-allograft? Well, we'll break it up, I guess, into 4 areas. So first of all, I guess, is conventional chemotherapy and or radiotherapy if there's localized extramedullary myeloid sarcomas. Number 2 is the most important one that I'm going to spend the majority of the time speaking on, and that is augmentation of a graft versus leukemia effect. And the other areas of importance, which are really looking at targeted therapies that may be emerging, which offer hope to block specific pathways in clones relapsing and show promise. And also I'll touch on some novel immunotherapies that clearly offer a role for relapse post-allograft. So what about in the area of augmenting a graft versus leukemia or a graft versus malignancy effect? Clearly, cessation of immune suppression for those patients still on immune suppression at the time of relapse has the ability to induce graft versus host disease, and in some patients, a graft versus malignancy effect. But it's usually not sufficient to have any meaningful long-term remission or good outcome. But for those patients who can cease immune suppression and do not develop any graft versus host disease within a fortnight, there is an imperative to induce a graft versus malignancy effect. And the 3 options we really have at our disposal here is a donor lymphocyte infusion, pegylated interferon, and I'll talk a bit about our experience with this form of immunotherapy. And then lastly, I guess the concept of a second allograft, potentially with an alternate donor, to try and induce a stronger graft versus leukemia effect. So DLI has been the backbone of our approach to treating relapse of leukemia post-transplant. It's important in all hematological malignancies to note that the graft versus malignancy effect is highly variable, and so the responses to DLI from published series are quite variable, as one may imagine. With at one end, we've got CML with the strongest graft versus malignancy effect evident, and at the other end, acute leukemia or Hodgkin lymphoma, where those effects of graft versus malignancy effect are less marked, and the successes of DLI may be less apparent. And that leads to really quite variable efficacy. So when we look at CML, we really have seminal studies from the late 90s which show that DLI is able to induce excellent responses and excellent long-term disease-free survival for patients relapsing, particularly in chronic phase CML. But even in patients with accelerated phase or blast phase, we see 50% disease-free survivals in these series. In the case of AML, those effects last a lot less notable and potent, and certainly DLI alone for active malignancy has shown very poor long-term outcomes. So any responses that may be achieved seem to be very short-lived. So cytoreduction or control of disease prior to DLI clearly is important in this disorder. And this lower curve here really shows the outcomes of a key series from the United States, and again, a bit old at this stage, but showing that in patients who receive intensive chemotherapy, get control of their disease, and then receive DLI, that more favourable long-term survivals can be defined. And again, time to relapse of greater than 6 months seems to be the prerequisite for any meaningful benefit from DLI, even in patients achieving a second remission from chemotherapy. So what other important things are there to consider with DLI? Well, I guess the risks are important, and graft versus host disease is why we're doing it, to try and induce a graft versus malignancy effect. And we would anticipate this in 50 to 60% of patients from the data we know. But if we look at patients who respond, it's about 90% of those patients who will have experienced graft versus host disease. And obviously, chronic graft versus host disease is what we're chasing, but clearly sometimes we may encounter both overlap GVHD, chronic and acute, occurring together. Aplasia is an issue, and using GCSF mobilized donor stem cells with donor lymphocytes is a way of minimizing and shortening the duration of bone marrow aplasia, particularly post-chemotherapy. And we can anticipate a treatment-related mortality of 5%. What about the dosage of DLI? Well, clearly, bulk DLI is associated with greater rates of severe acute GVHD and potentially fatal GVHD. And so doses generally above 5 by 10 to the 7 per kilo CD3 cells can be associated with higher rates of acute GVHD, particularly with unrelated donor DLI infusions. So as a practice, incremental DLI is increasingly used, particularly when DLI is collected in advance for further therapy. And that certainly has been our standard of care to minimise the risks of severe and life-threatening GVHD, but potentially still gaining the benefits of DLI. Important things about DLI is that the time to response is really not immediate. And certainly from CML data, we see that the maximal effects are seen at sort of 40 to 45 days post-infusion, and some patients still respond at 11 to 12 months, which is clearly only an option in an indolent disorder such as CML, which is potentially one of the reasons why AML is so challenging to treat at relapse with DLI. So what are our experiences of DLI here at our institution? Well, we certainly have a series that we've been able to publish and look at retrospectively. We've been able to have some patients who have received DLI, and we call it GDLI, so GCSF mobilized stem cells, cryopreserved, and excess cells which were available, again with donor lymphocytes within the product. And these patients that had access to these cells could then be directly compared to patients who didn't have access to DLI, but equally were matched in all other disease criteria and received similarly intensive chemotherapy prior to stem cell infusion with FLAG. And certainly found no clear impact or benefit of DLI in our patient group. Significant proportion of patients, whether they received DLI or not, did actually go on to develop graft versus host disease. And it was the development of chronic graft versus host disease post whether patients receive chemotherapy or DLI, which determine survival the most. The independent predictors of overall survival were chemosensitivity and new chronic graft versus host disease. So again, patients who don't attain a remission to flag, there's limited benefit of the DLI that they have received, which potentially explains some of the loss of benefit that we saw in our cohorts. So with this in mind, we set about to find a more novel and new way of approaching the treatment of relapse in patients post-allogeneic transplant. So we designed and ran a prospective phase 1 and 2 study, which recruited patients with all hematological malignancies relapsing post-transplant. The vast majority did have acute leukemia, but there was potentially 20 to 30% who had either lymphoproliferative disorders or myelodysplastic disorders. And patients were taken off their immune suppression. They received flag reinduction therapy. And then at day 21 onwards, if they had adequate count recovery, they started on an escalating dose of weekly pegylated interferon 2 alpha, also known as Pegasus, starting at a dose of 45 micrograms subcutaneous once weekly. This was escalated each week, depending on counts, blood counts, and the absence of any GVHD. Induction of any GVHD led to either the temporary cessation of the pegylated interferon or institution of specific therapy, namely steroids for GVHD. The maximum dose was 180 micrograms weekly of pegylated interferon. And what we looked at was really overall survival as a primary endpoint, but secondary endpoints of safety, GVHD, and immune biomarkers for correlating response. And what we found more pleasingly was a better 2-year overall survival of 31%, was very well tolerated, and we were able to induce graft versus host disease in 62% of patients, again in a similar median duration as we might anticipate with DLI of 42 days. And pleasingly, the majority of GVHD induced was that of a chronic phenotype, with only 7% developing acute GVHD. Treatment-related mortality was low, and only 38% of patients actually needed to proceed to DLI. So patients could proceed to DLI if they, on the maximum dose of pegylated interferon, had not developed GVHD. So it's a pleasing way of inducing GVHD, getting good anti-leukemia effects, but preventing the requirement of collecting DLI in about a third of patients. And again, we found that GVHD correlated with response and survival. The biological correlates showed that potentially defining specific lymphocyte subsets in large numbers pre-starting pegylated interferon was associated with better responses. But more work's needed to understand why this may be and how this may be manipulated. So what about second allogeneic stem cell transplant? Well, there's no high-level data, though there remains a number of retrospective series that have looked at this, and essentially in a very select group of patients, most series, they represent about 6% of relapses occurring. A second allograft may be offered. The prognostic factors seem similar to those that we've defined, so later relapses seem to be associated with better outcomes with the second transplant. Patients under the age of 20 again comes out as very important, and patients being in remission prior to the second transplant. This large series from the IBMTR shows that patients who were less than 20 who had a late relapse had quite impressive outcomes in their publication from a second allograft. So certainly in our younger patients with late relapses, this shows great promise. When we look at more recent data, so the MD Anderson's recently published in the last several months, their outcomes of second transplants, and in about 91 patients over a decade, they show quite encouraging survival of 36%, but with very brief follow-up there, approaching 2 years only. But they found very similar findings that time to relapse is very important. The benefit of an alternate donor is something that we don't have data to support either way. There's unlikely to ever be high-level data supporting this, but certainly the MD Anderson series shows really with increasing time, this has become the standard of care, whether using a haploidentical donor or an alternate blood donor for relapses, increasingly being done in that series. So what are the novel approaches to treating relapse? So I guess disease specific, if we think about AML, we have potent tyrosine kinase inhibitors like gilteritinib for FLT3 mutated AML that show great promise. And certainly in the seminal phase 3 study showing superiority over traditional chemotherapy, 20% of patients had relapse post-transplant. So this is important to be mindful of. IDH inhibitors show great promise and great tolerability, although again there is a caution here that more recent randomized placebo-controlled data has been disappointing from the Identify study. And we also have, I guess, hypomethylating agents with venetoclax. Again, whilst this is an encouraging combination with better response rates, the tolerability, patients post-transplant remains an ongoing challenge. So in the area of ALL, we have CD19 CAR T cells, and in Australia, we're able to access Tizacel for adolescent and young adults relapsing post-allograft, which is encouraging. For older patients, we really need to link them to clinical trials to access CD19 CAR Ts. And we have inotuzumab with concerns obviously around veno-occlusive disease, blinatumomab, and TKI, but all these are measures to control disease whilst inducing a graft versus malignancy effect. So what about in the area of lymphoma? We have, I guess, monoclonal antibodies with drug conjugates such as brentuximab, which have been used in combination with DLI for Hodgkin lymphoma, published quite widely there, as excellent tolerability, but again, still issues with efficacy. Polatuzumab has increasingly become a useful bridge to CAR T-cell therapy for patients relapsing. And we have the emerging area of BiTE and duo antibodies, which show encouraging results in the treatment of DLBCL relapsing either prior or after allograft. And then I guess we have CD19 CAR Ts for DLBCL as an option there. The concern really is around checkpoint inhibitors and their feasibility in a post-transplant setting, because we clearly have a safety signal of quite severe and overwhelming GVHD. So whilst there are small publications of the use of them, we would use them cautiously given the toxicity associated with them. So in conclusion, relapse is the commonest cause of treatment failure post-allograft. Survival post-relapse is poor. Key determinants of survival is time to relapse, chemosensitivity, prior GVHD, and age. Augmentation of the GVL effect is best undertaken post-transplant with cessation of immune suppression, dose escalating pegylated interferon, and or DLI. Second, allograft offers an opportunity for a select group of patients who are young, have a long period from transplant to relapse, but it has the potential to offer them long-term survivals. And novel approaches to preventing and treating relapse are really needed, given this remains our biggest area of unmet need. So I would like to acknowledge all the team here at the Royal Brisbane and Women's Hospital, including all our clinicians, data managers, nurses, and some of the collaborators from around the country, and Kieran Berghofer, who has been integral in running our studies in the biological correlates. So thank you very much for watching, and thank you.
So thank you very much, Dr. Curley. So that was a fantastic talk on a difficult topic. So with this, I think we're done with all our presentations, and we're open for questions and panel discussion. I'll kickstart with a question to all the presenters. We have transplanters from across the country and also Dr. Curley from Australia. So my question to all of you, and would like to have your views on, would you allograft an ALL patient who is in CR1 but is MRD positive? Bearing in mind that not everyone here can access novel agents like blinatumomab or inotuzumab. I would like Dr. Monira to first give her views on that.
And thank you so much for having me here. You see, that's the conundrum, right? When you look at the data and it says evidence-based is MRD is the worst prognostic indicator, but you really have to look at the protocol in which you're treating the patient. And at our institute, we typically use the BFM protocol, which allows us to escalate and according to the MRD at different time points. So if after induction they're MRD positive, I will still continue those patients on the consolidation and recheck MRD at a later time point. I don't typically, but I will be sensitized that these are probably the patients who are not going to do as well. Am I going to be just pull the plug and say, okay, I'm going to transplant this patient now? The answer is no. So it really is about understanding the protocol that you are treating the patient on and following this up. Persistent MRD positivity, you know what's going to happen there. So that's my short answer to a very difficult question.
Dr. Ayaz, your take on this?
We have actually had some access to blinatumomab. We have given it to about 10 patients. And I think that MRD positive patients I will not take to transplant. We have to have them because the chance of relapse is more than 90%. I know you've had some experience. You presented a patient or two that did well, but as a institute policy, we do not proceed to transplant if they're MRD positive.
And in the armed forces unit, Dr. Kamran, do you have a similar policy?
Yeah, I would agree. Of course, MRD is a major predictor of outcome after transplant. So I would agree, you would try whatever you've got at hand to control the disease. Because once a patient relapses after transplant, really there's not very much to do. So I think that's the right path to go.
And finally, Kamran, do you have anything to say? I mean, we're talking about a young patient who is in CR, but MRD, let's say 0.1% or not 0.04% is still showing up.
Yeah, look, I think clearly the international data is very compelling that the outcome is very poor when you're MRD positive. So if you have the option of modifying that, I think that's clearly the option to take. Our local experience was we didn't really find such a huge poor outcome really for MRD positive ALLs coming into transplant. So I think it really does, the importance is really, as we heard from Dr. Monira around the regimen used up front. I think if you're MRD positive and you've had hyper-CVAD up front, I think your outcome is actually probably not as bad as if you're MRD positive and you've had a BFM style induction. So I think the therapy you've had is quite important.
That's great, thank you. So I think there's another question around steroid refractory graft versus host disease. So do you think ruxolitinib can now be considered as the standard of care in steroid refractory GVHD of all types?
Yeah. Sorry.
Yeah, Dr. Ayaz.
I think what we do is depends on what is available and what type of GVHD are we treating. If it's just skin GVHD, I've used off-label tocilizumab in a few patients with some success. Ruxolitinib availability, although it's FDA approved now for GVHD, in Pakistan it's only approved for P-Vera and MPNs and not for this indication. So if we have some in our drug bank, we use that. If the patient can get hold of it somehow, we use that as a second line. So that is the go-to drug. Otherwise, we'll use whatever we can find, including ATG, sirolimus, infliximab, all of which, I think the major mortality we see is with the gut GVHD. When your patient is having 3 liters of diarrhea a day, I think the mainstay, once you fail steroids, and if you can't find Jakavi, is sportive care. You have to somehow maintain their nutrition and volume and electrolytes and hope they'll get through this while you get hold of one of the second line agents. So yeah, I'll give Jakavi if I have it, but you always have to have a plan B, C, and D until your options are exhausted.
Yes, I agree.
Actually,
I think, yeah, Dr. Kamran.
Yeah, sorry. So we do have access to Jakavi for patients with graft versus host disease, and that's through the through a Novartis program where they're providing it free of cost for, because it's not an registered indication here in Pakistan. And in fact, we've had very good results with Jakavi in acute graft versus host disease. We've used that in, I think, quite a significant number of patients with very good results.
And Kamran, I think you did participate in the REACH 2 and REACH 3 trials. What's your view on that?
I would think that it is the new standard of care. I think the lack of survival data is always a bit of a concern, but I think the crossover in the study probably had a large part to play in that outcome. But I think our standard of care was ACAM, and actually it's cost neutral. So for a lot of centres, I think even if you do pay for it, it's equivalent to the comparator. But as we've been using that managed access program as well, which with great effect from Novartis, which is very helpful and great results, particularly hepatic and skin. But guts obviously a serious problem, diagnosing way too late.
Dr. Munira, do you have any comments?
Regarding ruxolitinib, it's a great drug. If you can get it for your patient and if you can use it, that would be advisable. Good responses, great responses actually with skin GVHD, not so much with the lung. So when you're looking at chronic GVHD, it's also important to know where the chronic GVHD is affecting the person. So that is my take on that. Gut and skin, it does phenomenally well. Lung, not as much.
I think in addition, what I find in this patient group is the infective complications they start to get with all the immunosuppressive drugs. So Rux has a good impact from that perspective as well, that although it does immune suppress you a bit, but not to that extent. So I think Dr. Usman has a question as well to discuss.
Hi, it's Usman here. So my first question is with Dr. Munira. Dr. Munira, just ALL and pH positive ALL, we have already talked about it. If we have got a patient who has relapsed 7 months post-transplant in CNS but does not have any peripheral disease, so how you would kind of go by this patient? We had recently, and we kind of have put heads together and discussed a lot about it. I was wondering what's your thoughts into it. The second question in the same context is that we have got quite a few number of patients who actually in the past, because of fertility issue, could not get a transplant. But in those patients, we have seen quite a bit of CNS relapse while they were on imatinib maintenance. What's your experience in this regard?
So my question to you for the first question would be, what kind of TKI prophylaxis were they on?
So they were on imatinib.
Right. So we do know that in the TKIs, dasatinib has the best blood-brain barrier penetration. So if somebody with an isolated CNS relapse, with the extramedullary relapse with the normal bone marrow and MRD negative, then treating with intrathecal, with probably switching to dasatinib would be the way to go. I don't know what the role of DLI would be if you have 100% chimera when you are almost 7-8 months post-transplant. So that would be my take on that. With regards to your second question, you were talking about patients who do not undergo a transplant and have CNS relapses. Again,
Yes,
it would be switching to a TKI to one which has got a better blood-brain barrier penetration. If you can get hold of blinatumomab, that would be the way to go. Also, it's also important to know whether this is bone marrow relapse with extramedullary or it's just isolated extramedullary. So you can kind of divide it'll have to be very patient specific. So now when you're talking about somebody who cannot get a transplant for, I'm assuming, financial reasons or does not have a donor, then in the relapse setting, they're more likely whatever you do is going to be palliative. So they will eventually have systemic relapse. I would be interested to know what Dr. Kamran and Dr. Ayaz if they have any other ideas regarding this.
So I think the other problem is that in Pakistan, we do have got imatinib and nilotinib via program, which is a government-based program, but dasatinib we do not have, which has got a better CNS penetration and better outcomes as well. So for Dr. Kamar, I've got a question around that. You've elegantly talked about haplo transplantation and haplotransplantation in Pakistan as well. And as we know that we don't have a registry, donor registry for bone marrow transplantation in Pakistan. So how you foresee that, do you think that with haplo, more expertise coming into Pakistan, do we really need a registry, or we should still try to strive for having a BMT registry as well in Pakistan? What's your thoughts into it?
Really, I think, okay, that's a question that a lot of us would have, right? Considering the, the wide availability of haplodonors. But there would be certain patients who would be exceptions, like say patients who are, say, an adopted child, or patients who do not have children of their own, or there's a genetic disease in the family and really you can't go for a haploidentical donor. So I certainly think, and I certainly hope that we can, look forward to having a time when we have a registry in Pakistan.
Okay, thank you. So Dr. Ayaz, what's your thoughts on the same question, which I asked Dr. Kama?
I think I am biased. I trained in the US, most of their transplants are mud. And I think we have to have a registry. I have several patients who have a high DSA. So haplo is not an option. Basically, we watch them die because there's no mud. Also, even if you have a small registry, you come into that reciprocal pool where other registries will exchange donors with you for free. So I think with a country our size and with the so few ethnicities compared to like US, we can manage. India has 4 registries, Iran has registries. I think we can and should have a registry, and that'll save many lives.
Well, I think that's thanks a lot for your input. I think I will put back the hosting to the Dr. Waqas. Dr. Waqas, over to you.
Yeah. So I think I have another question for the panel. So for ALL, who is, let's say, over 35 or 40 years of age on an adult protocol, so we are now shifting towards an adult protocol like HyperCVAD, for instance, would you allograft all of them in their first remission, or anyone would actually wait till they relapse? Dr. Ayaz, particularly, we'll start with you if you have any comments there.
I don't treat kids until 12. For everybody above 12, we use HyperCVAD based on MD Anderson data, which is probably biased. But no, we do not transplant everyone. I have several patients who are compiling the data, TALL, BLL, who are in remission on pump maintenance years out. So no, everybody does not get a transplant. I think in BL, even the Philadelphia ones, I'm reluctant to transplant now. We are moving to the MD Anderson data. If they can afford and range blinatumomab, we do not transplant them. We go for a blina with ponatinib or blina with dasatinib based on the MD Anderson data, which is still few patients, 30, 40, 50 patients. But it's traumatic to see patients die of acute graft versus host disease and have relapse post-transplant. So I think I think the future of ALL will move away from transplant, just like it did for CML. And that is the hope.
And you use that for your older adults as well, over 40 years, say someone who is 35 or 40 years or older.
Up to age 55, even 60, if they're in good functional status, we go for hyper-CVAD. Then in patients who are not in good functional status, we use mini hyper-CVAD with a TKI if possible. And we've had patients in remission for years after mini hyper-CVAD. It's just tough, you know, you lose patients, infections are frequent. So physiologic age, if they look good, they act good, they are walkie-talkies, we hit them hard.
So Kamran, your take on this?
Yeah, I know it's a tough one, but I think non-relapse mortality is a key factor here in transplant, and the non-relapse mortality of this group is the lowest of any we treat. Sort of, 10% max, sort of 5 to 10%. Obviously, when you're getting up to around the age of 60, it's a different story. So I think that's heavily biased what our approach. So if we're truly using a hyper-CVAD-like regimen, we would anticipate a survival inferior of 50% with a non-transplant approach, while we would expect about a 70% survival for our cohort if we transplanted first remission. And I think getting patients to a second transplant is the issue of ALL, and the outcome of a transplant in second remission is clearly pretty poor. So it's a tough one, but I think if we're using a non-BFM style therapy up front, as you know, our outcomes are best with transplant first remission. So if patients are fit enough, if there's no barriers, we think the non-relapse mortality will be low, we would be in favour of transplanting first remission.
Dr. Kamran, so it really comes down to what is your expectation of your outcome with hyper-CVAD alone without any allo transplant up front. So what's your practice at your center?
Okay, so we are a transplant center and we favor transplants. I would agree with Dr. Curley. That's what we would do. Once a patient is in CR1, we're likely to get the best result. And particularly, I think in older patients, it would be harder to take them into a second remission once they relapse. And that would, again, be a very difficult situation then. So once they're in a good first CR, I think I would want to transplant them. Unless, of course, there are other factors that, would make the outcome for transplant. I do have a question for Dr. Curley, if
yep, sure, go ahead. Yeah,
if I may ask it. So I really enjoyed your talk, an excellent talk, actually, and a very difficult topic. So you've talked about using interferon for patients in relapse to induce a graft versus leukemia and Dbst. So is that an approach that you would use in every patient, I mean, like in most patients, or is there a certain subset that you're going to be using this particular approach on?
So I think it's primarily those that are not rapid relapses. I think those that are sort of relapsing very quickly, the reality is that the outcome's very poor. So I think only in those really fit patients would we be going down that line. But I think later relapses, that is our current standard of care, just as a way of inducing a graft versus malignancy effect pretty rapidly without going down the DLI line. I guess that the exception is the really young patient who probably relapses a bit later, and the patients had no GVHD, and is this the rare circumstance where we would be going for a second Allo? So, but that's a minority. It's really the majority of our relapses we would be treating with pegylated interferon currently, and DLI if needed. But like I said, a lot of the time we don't need to use DLI, which is significant benefit for the donor.
you get similar rates of GVHD, and for the follow-up we have similar outcomes. And it's still not very good. It's still a major problem, but I think if we can target more disease-specific therapies by incorporating drugs like gilteritinib and inducing GVHD, we're going to see better outcomes. But yeah, it is our current standard.
Okay,
Thank you very much. I think we'll probably bring the session to a close now. I thank all the presenters for their excellent talks, and all the best. And I think next year, hopefully, we'll have a physical meeting, and I'm looking forward to seeing you here physically. Thank you all very much, and
Thank you.
goodbye.
Thank you.